A very big hello to all my dear students. Welcome to the T2O series of ophthalmology in your favorite channel, You and I with Dr. So, Neetpg, are we ready? We're going to take this discussion further. And let me remind you, it's a quick revision of 15-20 minutes based on the important topics which are asked in your okay? So discussion will all be mainly image based. Let's start with this. What do you see in this image? If you look at this image, we zoom it also for you. See these new blood vessels, right? Actually, what are you looking at? What are these new blood vessels? These stuffed of new blood vessels at, right? This is what is NVD, and we are talking about neovascularization at, okay? And we can see some more tuft away from the disc. Yes, this reminds us we have to remember and revise today about diabetic retinopathy. Okay, so we are going to revise today the diabetic retinopathy. If you talk about diabetic retinopathy, what are the questions? Questions based discussion here. First of all, is most important factor for occurrence of retinopathy in a diabetic patient. So, who are the patients who will get the retinopathy? So, most important factor, as you all know, we will answer is duration of diabetes, right? This is most important. So if a patient is diabetic for around 20, I'm talking about longer duration, like around 20 to 30 years, then even if he's controlling his blood sugar, he can get retinopathy. Okay. And then this is the second question they ask you is, what is the second most important factor? Second most important factor, if they ask you, it is, of course, you all know, is glycemic control, which also means that if you're not controlling your sugar, then you can get it the next day, right? Anytime. It can be very soon. So glycemic control is very, very. Of course, we know some other risk factors that quickly revise with me: hypertension, any associated nephropathy, pregnancy, right? So these are some very important factors which will determine whether this patient. We come to the next question. They ask you about is what is the first sign of retinopathy, diabetic retinopathy. If what is the first sign of diabetic retinopathy? Look here, this is the angiography, fluorescein angiography slide showing all these hyperfluorescent dots. So these are nothing but microaneurysms, and this is what is the first sign of diabetic retinopathy, microaneurysm. The next question that they ask you is where are the microaneurysms? Which layer of retina? So please, we are going to answer NFL layer. Initially, our answer was different. Years back, please change it. We answer layer, not layers. It is layer, right? Okay. So these are the two questions. This question in diabetic retinopathy is, of course, we know type 1 and type 2. So in which type the chances of getting retinopathy is more? So we all know it is more, next question right here, it is more common in type 1. Then they ask you, when should you do the first fundus examination? Again, it depends on what type we are talking about. So first fundus examination, if we talk about type 1, we will answer in type 1, we should go for after 5 years because that is the time we expect some changes in the retina. So after 5 years. And if I talk about type 2, we don't know since when this patient is diabetic, it generally is diagnosed. And this is the reason we answer we should do it immediately. As soon as you know that a diabetic type 2 patient, we should go for fundus examination. These are all very, very important exam questions. So immediately, now you this, right? Okay. What is the next question they ask you? Is of course we have to know about the different clinical features. We should be knowing about the different stages. So we all know there are two ways of, very quickly I am speaking verbally, only two ways of classifying. One which is still going on is background diabetic retinopathy, pre-proliferative or proliferative, right? And common sense background diabetic retinopathy means what? It is less hypoxia. More hypoxia, it goes to pre-proliferative stage. Even more now it goes to. This was our initial classification which we used to learn. Let's keep talking about this first. So background, we just simply and very quickly learn like this. You get microaneurysms, of course, and you can also get all types of hemorrhages that like and exudates. Then it becomes a bag. Simple way of learning. Now, these days, what they will ask you, and of course, when pre-proliferative, if you want to revise further, in pre-proliferative stage, what do you see? Very quick revision here. In pre-proliferative, we get more hypoxia, so more damage, more debris, and more debris means more number of cotton. Number one. Number two, venous infarcts are there, so they look like large blood ham. Number three, IRMA, intraretinal microvascular abnormalities, which are shown. Number four is mainly looping and bleeding of. These are some additional changes in pre-proliferative. Apart from the features of background, this if we are getting this, now this is a state of pre-proliferative diabetic retinopathy. Okay? And what is proliferative? When you get a neovascularization, which can either be at this or here. This is your proliferative. If you're clear with this, a quick revision. How do you learn the ETDRS classification? That is again very, very simple. So first of all, let's look at the slide because that is also asked in the exam. So one of your previous exam question was, what are these? So please remember and learn to recognize these are what? They are hard exudates. These are all yellowish deposits that you're seeing here. These are all hard exudates. This is your blood dot hemorrhage, right? So this is the dot hemorrhage. So we are getting dot and blot more and we are getting hard exudates. So this is nothing but a background diabetic retinopathy. But what is the new classification ETDRS? Let me first write that and then we come back to the slide so that it is more easy for you to read. So yes, we will write it here. When you talk about very quickly ETDRS class, you have revised background, pre-proliferative and proliferative with me. This is divided into non-proliferative diabetic retinopathy and proliferative diabetic. Remember this. And non-proliferative, a recent classification says it can be very mild, it can be mild, it can be moderate, it can be severe, and it can be very severe. This is what is asked again and again and again in your exam. What is this? Okay. So very mild is nothing but only microaneurysms. What is mild? Background diabetic retinopathy. All the features of this. What was that? That means microaneurysms, and along with that, we are getting all the exudates and ham. Right? Then we talk about moderate. Moderate, I just verbally quickly revised with you, was about pre-proliferative. So all the features of pre-proliferative diabetic retinopathy, moderate NPDR. And what is severe? This is exam question. Again, it is defined by, what is severe defined by? So severe is defined by 4:2:1 rule. Okay. So what is 4:2:1 rule? Says that either, I'm again quickly revising verbally. If you want to write, you can down. This 4 means all 4 quadrants we are having hemorrhages and microaneurysms in all 4 quadrants. Or either we get this, or we are getting looping. So let's have a look. This is the looping. Okay, this is what we call as looping of the vein. We can see these are blot hemorrhage. Okay, very small ones are called dot hemorrhage. This is the looping. Similarly, you can get beading. What is beading? When the vessel looks something like this. So if you get it in any 2 quadrants, then this is also severe NPDR. So I said hemorrhage and microaneurysm in 4 quadrants is 4:2, either this in 2 quadrants, or what is one? IRMA, intraretinal microvascular abnormality, in any 1 quadrant. Okay, so this is what is severe NPDR. Now, all of you, if you're getting more than one feature of this, so either 4 or 2 or 1, then it is severe. But if you get more than one feature of the severe, then you call it very severe NPD. Okay, so here this is severe is defined as 4:2:1 rule, and then very severe NPDR is more than 2 conditions of this rule, more than 2 factors or features of 4:2:1 rule, right? If you're getting, this is what is your very severe Okay, so this and PDR, of course, is proliferative diabetic. There you're getting NVD or NVE. Okay, I think this was a quick discussion here. You have to revise it. We come back to the slides here. Now, what are you seeing here? If you look at this slide, compared to this one, meaning there's a lot of cotton wool spots. These are what are called cotton wool spots. You all know these are axonal debris, they are dead axons, right? And then I can see a lot of flame-shaped hemorrhage. I can see, then you can see the large blot hemorrhages, right? So what is this? And some even old laser burns I can see. So what is this? This is mainly pre-proliferative. Okay. So this is a pre-proliferative diabetic retinopathy. These changes. But yes, what is important to understand here that more number of cotton wool spots, looping and beading, IRMA, everything goes towards pre-proliferative. Then we talk about the next stage is when you get neovascularization. Can you see that the new blood vessel is here? This is NVD. Okay, so this is your case of proliferative diabetic retinopathy. Of course, we can see these are cotton wool spots, and this is again a large blot hemorrhage. These are flame-shaped hemorrhage. These are the flame-shaped hemorrhage, and so, right. So this was about your different stages. What are you looking at this? This is again an angiography. This is the tuft of blood vessel. What do you call this? These are in your neovascular. Nothing but NVE, neovascularization. All this stuff, this is why here also. So all these black arrows which you are able to see, these are all indicating your neovascular tuft. Can you make it out? These black arrows? Yes, this is all neovascular. And the yellow ones are actually showing you, these are showing you the necrotic area or hypoxic area because of which there has been this new. Okay. And very quickly, diabetic retinopathy, if it is non-proliferative DR, our first line is intravitreal anti-VEGF injection. Second line would be, so you have to understand this way very quickly. If your diabetic retinopathy is with no macular edema, it's a non-proliferative, we will wait and follow. If there is a macular edema in a non-proliferative, what do? First line is always anti-VEGF injection. Second line would be laser. And if it is a neovascularization, our first line becomes laser and second line becomes anti-VEGF. Okay, yaad ho gaya? Okay, and when you talk about lasers, we should know PRP. So here these are all laser burns. They are nothing but laser burns. As you know, we first give a temporal barrage here. We make a boundary like this, temporal barrage. And after this, we are going to start lasers always from, this is exam question, we answer. We start from inferior quadrant. Always start from inferior quadrant. Why do you start from an inferior quadrant? Why do we have to start from inferior quadrant? Because if I'm doing it from superior and there's any bleeding, the blood settles down. Now I can't see anything. Therefore, the whole procedure has to be always start from it. Okay? And generally, how many number of burns will depend upon severity of the disease, but average you should remember the number of the burns is around 2000 that we give in PR. These are few questions on PRP. One was this one. Second was from where do you start? Right? Okay, we come to the next slide. What else you should revise? This. What are you looking at? What I am looking at is a very thin sclera that the uveal tissue is visible. And what I see is ectasia at this area, which is a ciliary area. Yes. So your answer would be this is actually scleromalacia perforans, which is leading to what? You will answer is leading to ciliary staphyloma. Anybody remembers what is staphyloma? It is ectatic condition of eyeball with herniation of uveal tissue. So that is a exam question. Number one, scleromalacia perforans is generally associated with rheumatoid arthritis. One question on staphyloma, most common type of staphyloma. If they ask you, do you all remember staphyloma? Very quickly, if I make a diagram here, revise with you about staphyloma. If it this ectasia is happening anteriorly, this is called anterior staphyloma. If it is happening at the limbal area, what is this called? Intercalary staphyloma. You remember this? Intercalary staphyloma, right? If it is at the ciliary body area, it is ciliary, then it can be equatorial, and then it can be posterior staphyloma. So these are the different types of staphyloma. Treatment is staphyloma. So if they ask you, the next question is most common type, you should answer it is always posterior. What is the cause of posterior staphyloma? How does it become static? You will answer it is due to pathological myopia. Pathological myopia. Right? Okay. That was about this slide. Come to the next one. Look at this one. It was also a recent exam question. Can you see there's a ring type of thing which is inside the cornea? These are what are called intacts, isn't it? We call it Ferrara rings. Ferrara rings. So mainly where are you using it? Causing a stretching and decreasing the curvature of the cornea. So mainly in keratoconus or maybe post-LASIK if there is any, yeah, we can use it, right? So it is inside the stroma of the cornea where you're fitting this ring, right? And can you see there's a gap? So there's a 150-degree arc here. Look at it. So 150 degree arc here, 150 here, and around 30 degree, 30 degree gap of 30. Right. So generally it can be used in post-LASIK ectasia or mainly in kerato. Okay. So this is asked in the exam. This was the exam question. So we have to revise. Again, this is also have a look. This is same intacts. This is how it looks. The intacts. Okay. So it was one of the means of commonly used in refractive surgeries. Earlier, it was used only purely for a refractive reason, but this is also a refractive reason only, but lesser and lesser used now, mainly in case of. Okay, so that was all a very, very quick discussion and revision. Please revise these topics before exams. Hope you enjoyed the session. Thank you so much. Be blessed.